Okay, well, welcome everyone. I'd like to thank you for joining us today. I imagine we'll have a few more folks joining us over the next couple minutes. So I'll start out by just doing a little bit of introduction and what we hope to accomplish today. Uh, I assume if you are joining us today, it's because you know that there is a blood culture bottle shortage that's been ongoing for a couple months now, and with a little bit of an uncertain date as to when it might fully resolve. And a lot of organizations have been struggling with this. We in the western region of CMS Region 8 have been collecting information from a variety of organizations, health systems, hospitals around the region, looking into sort of what are the best practices and how can we have a better, more coordinated, coherent sort of regional approach to this. And we'd like to present today our summary of findings to date with some interim guidance. To do this, I have joining me today, I should say I'm Dr. Matt Wynia. I direct the Center for Bioethics and Humanities at the University of Colorado, and I'm an infectious disease physician and have a longstanding interest in ethical issues in disaster response, including issues related to triage. I co-chair the medical advisory panel for the Mountain Plains Regional Disaster Health Response System. Joining me as co-chair is our presenter today, Dr. Anuj Mehta. Dr. Mehta is an associate professor at the University of Colorado in pulmonary and critical care medicine, practicing primarily at Denver Health, but at a couple places around the city. Also joining us today as panelists and discussants are Dr. Tim Jenkins. Tim was brought in as a special consultant for this work. He did his undergrad at Boulder, Hopkins for medical school, and then wisely returned to Colorado and has been here ever since. He's an associate professor of infectious diseases at the university and practices at Denver Health, where he is also the medical director of the Anti-Microbial Stewardship Program. So he's got a lot of experience in some of the strategies for ensuring efficient use of limited resources. And then our second panelist is Robin Ebmeyer. Robin is also a member of our medical advisory panel for the region. She is a nurse at Intermountain Healthcare based in Provo, where she's also the director of emergency management at Utah Valley University. She has a long history of both practice in the ED as well as teaching and leadership in emergency response. So the strategy for today is that I'm going to turn things to Anuj. He's going to present important background information, as well as what we learned in surveying the systems and hospitals across our region about how they are managing this response and what some of the best practices are. We will then turn to Robin and Tim for some conversation. And at that point, I will also open it up to the audience for your questions and comments. We'd be particularly interested in learning how your organizations are managing this crisis, and any feedback, obviously, on what we've learned and what we're recommending as guidance here would be very much valued. This is, as all crises are, an evolving situation. And so we've intentionally labeled this interim guidance because I expect that we will be making changes to this over time as we learn more and as the situation evolves. So with those as preliminary comments, let me just turn things over to Anuj.
Thanks so much, Matt. I appreciate it. I'm just going to dive into our presentation, which is going to summarize some of the guidance that we've developed over the last couple of weeks. And just as a quick note, the Mountain Plains Regional Health Disaster Response, or MPRDHRS, it's a program that was awarded through the Department of Health and Human Services Administration for Strategic Preparedness and Response. It is designed to serve CMS Region 8 and improving medical surge and clinical specialty capabilities during an emergency. The website and a QR code to the website are there if you want to learn more about the MPRDHRS, which can assist in a lot of different areas during health disasters and incidents. The medical advisory panel, the unit that both Matt and I co-chair, is a subgroup within the Mountain Plains Regional Health Disaster System. It's a group of medical and public health subject matter experts, and it's designed during an incident or during a request for assistance to convene rapidly, virtually, review the literature around a specific question and come up with guidance. And that's what we've done over the last couple of weeks when one of our partner states asked for assistance in coming up with some best practices to address this current shortage. The contributors to the document that you'll see in a moment come from Utah, Montana, and Colorado, mostly across a wide amount of specialties, from adult and pediatric emergency care to pharmacy, nursing, critical care, and importantly, infectious disease as well. So this is a really fantastic group that I think all contributed to the guidance that we're about to discuss. Just some resources. These slides will be available after the webinar, and our guidance document is posted on our website. It's a QR code in the website, and then also it's a 6 to 8 page document. There's also a 1-page placard for more quick guidance that people can access at their leisure. So just kind of going into the situation a little bit, I think some individuals became more aware of the shortage affecting the BD Bactec blood culture bottles. In early July, the FDA actually announced the shortage on July 10th. It was a problem stemming from the plastic bottle manufacturing, not the media or anything else. And while Becton Dickinson has provided some updates along the way, it's unclear when the situation will be fully resolved. There was a recent statement, I think, from a couple of days ago that suggests they may get manufacturing capabilities back up to par by the end of September, but that, again, remains unclear. And they've circulated the idea of potentially using glass bottles instead of the plastic bottles. Glass bottles actually open up a different set of considerations as well. I know a lot of people use tube systems to transfer bottles and things. So those are some additional considerations if your hospital decides to start utilizing glass bottles. Just a little bit of background about blood cultures, and as an adult critical care doctor, I didn't know any of this until the situation actually arose, is that there are 3 major companies that run blood culture systems. The 2 biggest are Becton Dickinson, the BD Bactec system, which is affected by the shortage. Bioethics is a French company. They operate the BACT alert system, and they are not affected, nor is a much smaller company, Thermo Fisher, in their signal system in terms of the market share. So it's really just the BD Bactec systems that are being affected, and the bottles, unfortunately, are not interchangeable. You can't take a Bioethics bottle and run it on a BD Bactec analyzer. The bottles are incompatible. So if you have a BD Bactec system, that's what you have. To switch systems could be hundreds of thousands of dollars because it's more than just purchasing the bottles. Because it's 1 out of 3 manufacturers that's affected, the result has been actually quite heterogeneous and uneven. So some hospitals are affected because each hospital only has 1 system, while other hospitals are not affected. And that creates a lot of equity considerations that we'll talk about. A lot of health systems have actually started seeing significant decreases in their orders, large 1,000-bed hospitals have reported only receiving a handful of blood culture bottles at times. And so I think a lot of health systems that use the BD Bactec system are already implementing restrictive strategies to try and preserve their current supply. And, thinking about what the potential harm in the absence of blood cultures, what would the patient harm be? There's a lot of potential issues that could arise. If you can't check blood cultures, you can very easily miss bacteremia or bloodstream infections. Alternatively, if you initiate antibiotics because you have somebody with suspected sepsis, but you don't have blood cultures to really identify the specific culprit infection, patients may be exposed to overly broad spectrum antibiotics for a long time, which can result in side effects, C. diff infections, and breed resistance. A lot of our decisions about duration of antibiotic therapy is oftentimes based on where the infection is and if they have a bloodstream infection. And then oftentimes when you have persistent bacteremia, that's when you start hunting for deeper infections. And in the absence of blood cultures, you can't do any of those things. And so this is really can have direct harm to patients when you're unable to use blood cultures as we normally would. So in 2009, then called the Institute of Medicine, now called the National Academies of Medicine, conceived surge capacity along 3 levels of crisis management. Conventional care, kind of where you're operating using best data and best practices, there might be a shortage, but it really has minimal impact and you're not altering your practices too much. There's contingency level, so that's when the shortage is more severe and you are implementing restrictive strategies. That's a deviation from the standard of care when there wasn't a shortage, but that the limitations are still able to preserve patient outcomes, meaning that the harm to patients from the contingency strategies tends to be quite minimal. And the most extreme form are crisis strategies. And being very intentional using the term strategies as opposed to crisis standards of care, which is another concept that oftentimes involves a lot of governmental and emergency public health orders. But crisis strategies are the most restrictive forms where you're really rationing care. You're deciding that some people are going to get blood cultures and other people who normally would have will not be getting blood cultures. And the crisis strategies have the highest potential to impact patient outcomes. And we conceived the guidance around those 3 domains because this is a very classic way of thinking about either surge capacity management or shortage management. And the core principles that we really kind of explored and wanted to spell out in detail were increasing the yield. And so this is going to be really in that conventional realm of how do we make the blood cultures we collect more reliable and more accurate? How do we decrease waste? And this is going to be a combination of conventional and contingency strategies. Where are we collecting blood cultures where maybe we don't need to? Or where are we collecting blood cultures where, yes, we would typically collect them, but maybe they're going to be lower yield? And then the most severe is going to be that restriction and rationing, again, contingency and crisis strategies, where you're really making a hopefully data-driven and equity-driven decision about which patients are going to have blood cultures performed on them and when. And the bulk of the document that we prepared that's published on the MAP website, it really goes through and divides a lot of different strategies. That's a culmination of input from the American Society of Microbiology, from the CDC, from the IDSA, and we essentially created lists and divided them into these categories, knowing full well that there are some things that some might view as conventional, others might view as contingency, but really thinking about, one, increasing the yield. So for those, for the clinicians on the call, when we collect blood cultures, there's really 2 key things to make those blood cultures valuable. One of those is ensuring adequate volume. And different systems have different volumes, but for the BD VacTech system, it's typically 10 to 20 milliliters per bottle. And one reason why a blood culture may be far less useful is when you have a really low volume, and so you're going to have a low bacterial count or low infection count, and you may miss the infection. And so those blood cultures, when you have low volume in the bottle, they're somewhat wasted. And then also ensuring proper aseptic technique. We've all had blood cultures where, we presume that the infectious organism like coag-negative staph is a skin contaminant. And sometimes, it's inevitable that's going to happen, but sometimes it's also because proper aseptic technique was not used. And so if you ensure those these 2 strategies are being employed for every collection, you will increase your yield and potentially decrease the number of times you have to repeat blood cultures because the initial set was not informative. There's also a core idea here that in managing any shortage, you need to have accurate facility level tracking and situational awareness. And this is something that I think healthcare organizations are evolving as we're dealing with more and more shortages, both in medications and other equipment. So this is a concept of understanding your utilization rate or your burn rate combined with, understanding how many bottles you're getting in, how much are you getting from the manufacturer. And for the last couple months, that's been a moving target. People would be placing large orders and getting 10% of the order or 20% of the order. And so understanding how those two things interact on almost a daily basis is the only way that an institution can really have a good estimate of their supply on hand at the moment. And thinking about if they were to get no more bottles at that moment, how many blood cultures would they be able to collect, and then basing their restrictive strategies around that concept. Communication with leadership is really critical, and oftentimes regional coordination or coordination between hospitals is done by emergency managers or sometimes hospital leadership. So if the people that are involved in ordering the blood cultures are not communicating with hospital leadership, that's going to really impair any sort of regional coordination that can happen. And then there's also, these are things that I wasn't necessarily familiar with, but there's clinical decision support tools about which patients actually need blood cultures. A lot of them are data driven. They've been validated in different populations. One example would be the M. Shapiro tool. And so those are things that hospitals can consider deploying in their electronic medical record to help guide which patients are going to get blood cultures that are data driven. And then really the idea of reducing waste. So which patients do we routinely collect blood cultures on, or do some people routinely collect blood cultures on that really don't need them? Even in the absence of a shortage, these are patients that potentially would not need blood cultures checked. And so to consider waste or reduce waste, it's don't collect more than 2 sets at any given time. When I trained, if you were concerned about endocarditis, you would maybe check 3 or 4 sets at a given time. But really, the data doesn't support that anymore. So really restricting it to 2 sets of blood cultures at once. There is a approach to save sticks on patients to reduce the amount of pain they have from blood draws when they present to an emergency room or an urgent care or even on the floor, that people just draw a full set of labs and then send them off if an order goes in for that. Sometimes that involves blood culture bottles. So blood cultures would be collected and placed on hold. And if the provider orders blood cultures, well, then you don't have to stick the patient again. A lot of these go to waste. And they're never actually used or analyzed. And so avoiding hold cultures and only really collecting blood cultures when there's an order, a clinician-driven order for appropriate patients. Really avoiding blood cultures in low-risk patients that don't need hospitalization, so mild community-acquired pneumonia or lower urinary tract infection. These are patients that might present either as an outpatient or present to an urgent care emergency department who likely don't need to be hospitalized. And so these are not patients that necessarily need blood cultures, barring, clinical instability, immunocompromised states, and things like that. So you always have to think about the full clinical picture. But in general, these are patients that don't benefit from blood cultures being drawn. We all have had patients that have isolated leukocytosis or an isolated fever that's already been worked up. And so in those patients where you've already worked it up, you have not identified an infectious agent, and they're clinically stable, repeating blood cultures constantly is a very low yield, because there's a lot of reasons why patients may have a leukocytosis or a fever. And so not just jumping to the idea that you need to repeat the blood cultures repeatedly. And again, thinking about the whole clinical picture is going to be really important. A lot of times patients will have a repeat cultures drawn or surveillance cultures drawn for conditions like gram-negative bacteremia, so that you've identified a bloodstream infection, the causative agent, and then in some cases, people will order cultures to document clearance. But really, when there's no concern of an endovascular infection like endocarditis, there's no documented identification of Staph aureus or a Candida species, you don't need the documentation of clearance. If you have an E. coli bacteremia from a patient that has sepsis from a UTI, you don't need to document clearance there. And so not checking those clearance cultures will preserve the culture supply. For a clinically stable patient, it's not unusual to have fevers in the first 48 hours after surgery, and the chances of that being in a clinically stable patient, a bloodstream infection, are extremely low. And so most societies have agreed that this is not necessarily the people that need blood cultures in an area where we can reduce waste. In patients who are immunocompromised, obviously, if you present with a fever and you have neutropenia, there's going to be the initial infectious workup, and blood cultures are very appropriate in that setting. But for persistent neutropenia, some institutions may be checking daily blood cultures. And if there's an absence of clinical indication, even in the setting of neutropenia, then those cultures are going to be very low yield. So really think about the utilization in those patients. I mentioned the idea of skin contamination earlier, coag-negative staph. There are tons of other species that we all view as skin contamination. And so when you have 1 out of 2 cultures with coag-negative staph, those are patients that don't necessarily need repeat cultures when they're clinically stable. If you don't have a concern for an infection, if they don't have hardware, they don't have an indwelling line, and there's no reason that they should have coag-negative staph bacteremia, and you have a very low pretest probability for true infection, then repeating the blood cultures is likely not going to benefit the patient and likely just utilize a depleting supply. There are some patients that do need surveillance cultures. So if you have documented endocarditis, a documented Staph aureus or candidal bloodstream infection, you do need to check surveillance cultures, but it doesn't need to be daily, and you should be waiting at least 48 hours, and some organizations would argue for 72 hours prior to checking those surveillance cultures. So it's not that you avoid checking it, you just reduce the frequency to really preserve the supply. Moving into contingency strategies, so these are where we're starting to get a little bit more restrictive in how we approach this. This is when people's supplies are really starting to dwindle, where maybe you're not getting the orders that you want. Again, from a facility level question, this might be when hospitals want to start considering sequestration of blood culture supplies. So not just having them out in the open where they may get contaminated or fall or break. We're reserving them only for phlebotomy staff or other approved users. And a lot of hospitals have stopped allowing outpatient blood cultures in outpatient settings. So if you have suspected infections in an outpatient clinic, you would send that individual to the emergency room or an urgent care center to have the blood cultures drawn. While that may increase traffic to the emergency room, it's also going to triage patients appropriately for potentially more severe infections. And there's a lot of clinical strategies that you can implement to reduce the utilization of blood cultures. So again, we talked about that there are some patients for whom documenting clearance is necessary. Staph aureus infections, structural endocarditis, or candidal species. And our common practice is anytime I order blood cultures, I order 2 sets. But if you're documenting clearance, this is one area where potentially 1 set of blood cultures may be sufficient. If you know you have Staph aureus and you're just looking to see if you've cleared Staph aureus, you can likely do that with a single set of blood cultures. And then a slightly more restrictive form of deciding who needs blood cultures than in conventional would be not collecting blood cultures in patients who do require hospitalization but don't have sepsis and have relatively low concern for bloodstream infections. And this is going to be places where, empiric antibiotics are initiated and cover most of the bugs we worried about. So uncomplicated community-acquired pneumonia, non-purulent cellulitis in a patient without sepsis, uncomplicated lower urinary tract infections or cholecystitis or diverticulitis. So these are conditions where we all know the most common bugs that cause these infections, and we're going to start empiric antibiotics anyway. And if they're uncomplicated, they don't have sepsis, the chances of having a bloodstream infection are quite low. Not 0, but low. And so these are potentially patients with whom you can avoid checking blood cultures and utilize things like sputum cultures, urine cultures, and potentially consider early imaging. There's a deeper level of contingency strategies that you can also consider. And so these are going to be patients that are sicker, right? That you might routinely check blood cultures in. But again, where we have most anti-microbial stewardship programs are going to have a list of the most common bugs that cause certain infections. So these are people I would almost always check blood cultures in, but if you're really running into shortage, these are patients that may not benefit as much. So septic arthritis, and this is where you can tap the joint as opposed to checking blood cultures. You can cholangitis. There's classic set of bugs that are going to cause it. Now, in somebody who is rapidly deteriorating, you may want to check blood cultures, but uncomplicated cholangitis or pyelonephritis or moderate community-acquired pneumonia, where we know the most common bugs, if your institution is really running into severe shortage, this would be considered a deeper contingency strategies, and you may consider not collecting it in those patients. As we were developing our guidance, there was a lot of discussion about whether this is a contingency or a crisis standard. What's the potential patient impact in these patients? And again, since we're typically initiating broader spectrum antibiotics for some of these patients, they're going to be covered, and we're going to be targeting duration around the causative organ. Crisis strategies are our most severe restricted form, and these are going to be clinical strategies to reduce blood culture use. At this point, the facilities have implemented everything they can to try and track and reduce use. And so, for patients that have sepsis, consider only one set of blood cultures. And this can be very controversial. We know that the sensitivity of a single set of blood cultures is far lower than two sets of blood cultures. So you have a higher risk of missing a bloodstream infection. But again, thinking that this is the most severe rationing form, the severe crisis form strategy, that this may extend your blood cultures and may allow you to check blood cultures in more patients that require it to benefit the most number of people. In some settings, you may need to restrict blood cultures to use for only critically ill patients or severe immunocompromised states. So a patient that would normally have blood cultures checked, but is being sent to the floor and is not being triaged to a critical care setting. Maybe this may be something your institution has to consider as only the most critically ill patients or patients with really severe immunocompromised states. And then, we were thinking about the example of dialysis. If a patient who needed dialysis presented to a hospital that didn't have dialysis capabilities, the standard of care would be to transfer them to another institution. It's obviously a very different consideration with blood cultures because moving patients, it takes time, and blood cultures and antibiotics are highly sensitive. But in severe shortages, it may be necessary to consider moving patients from an emergency room to where there's no blood cultures available to a hospital that actually has blood culture availability. In those settings, and this may be more of a theoretical concept, but this would be something where if EMS identified a patient who had signs of septic shock fever, blood pressure being very low, not responding to fluids, en route, you may divert them to a hospital that has blood culture capabilities. But a key thing would be don't delay in giving antibiotics. In patients that are very sick, there's a clear hour-by-hour increase in mortality when you delay giving antibiotics. So you still have to clinically manage these patients, but you might need to consider kind of what the most appropriate setting is for that patient. We really, and a lot of the crisis literature has started talking about how do we decide when we move between conventional contingency and crisis strategies. And unfortunately, there's not a lot of data, and it requires a really complex understanding of what is your burn rate combined with what is your resupply rate, which is going to be different between different hospitals. But ideally, we have to consider equity in this and recognize that this has a heterogeneous impact. And so if one hospital has a lot of blood culture bottles and another hospital down the street has no blood culture bottles, and they're implementing widely different strategies, that can have a lot of equity implications. So regional coordination is going to be really important when thinking about what are the restrictive strategies being implemented and how do we share some of our resources. We would push that everybody, including hospitals that don't have the BD BACTEC system, should consider employing conventional strategies. Really, conventional strategies are the most data-driven strategies around who should receive blood cultures outside of a shortage. And so really just thinking about reducing healthcare waste in general, conventional strategies are a best practice list. And the idea of employing these even in non-BD BACTEC hospitals has some regional coordination considerations that I'll get into a moment. And then obviously moving from contingency to crisis, as I said, has to have accurate estimates of use, the burn rate, the resupply rate, and then considerations for outsourcing. We would make the argument that if you have a less than 4-week supply, hospitals should think about those more restrictive contingency strategies and not just utilizing conventional strategies, since the timeline for full resolution is unclear at this time. From a regional coordination perspective, as I said, local coordination when moving between levels is important. If there are some hospitals have been able to obtain an adequate supply of BD Bactec bottles, and if they have an adequate supply and a nearby hospital doesn't, and that type of resource sharing is something we would really encourage in terms of regional coordination. And then this idea of outsourcing, and this can be, you know, considering commercial labs. A couple of the major commercial labs don't use the BD Bactec system. But then also an idea that's being tossed around in the Boston area is if all hospitals employ conventional strategies, it could result in an excess capacity in the non-BD Bactec hospitals. So if you have the bioMaru system and you're reducing use and reducing waste with conventional strategies, you might be able to run some more blood cultures on your system. And so thinking about partnership between these hospitals, and can BD Bactec hospital order bottles, bioMaru bottles, collect the cultures, and then send them to a hospital that utilizes the bioMaru system with excess capacity. This obviously takes a lot of regional coordination, a lot of operating agreements between different hospitals. But again, as shortages become more common across healthcare, these types of regional coordination and cooperation are going to become increasingly necessary to dealing not just with this shortage, but other shortages in the future. It is important to recognize that the blood culture situation has a lot of implications for CMS value-based programs. So the SEP1 bundle for severe sepsis and septic shock, it's a way that hospitals are measured on quality, as well as it can impact the reimbursement if you're based on your rates of compliance with the bundle. Part of the bundle is checking blood cultures before antibiotics are given for patients that rule in for severe sepsis or septic shock. This is a webinar from 2018, so it's old and it took a while to find it, but this was an official CMS webinar that answered the question of whether one set of blood cultures would be sufficient to meet the CMS SEP1 bundle. And based on this, the answer is yes. A single set of blood cultures, if you're in that most restrictive phase, would meet that requirement. The QR code is a link to the full PDF document if you want more information on what CMS talked about during this webinar in 2018. And then just last week, CMS issued a little bit of an update. They're aware of the shortage. They're aware that the shortage has implications for the SEP1 bundle. They're not issuing any waivers at this time or additional guidance other than referring to people to what the FDA and the CDC guidance is. But they do recognize that all of the value-based purchasing programs and quality metrics can be reevaluated even retroactively during the rulemaking session that's going to be coming up, I think, early next year. And at that time, there may be changes to what would cause a hospital to rule in or rule out for compliance with the SEP1 bundle. So they're aware of it. They haven't made any firm rules. Obviously, CMS takes a while to make those firm rules, but they're considering a lot of potential modifications. And again, this is a QR code to the website for this announcement. The last thing, anytime you're talking about crisis considerations, is legal considerations. You know, as you deviate from what used to be the standard of care, or do you have legal protections? So the guidance within the document and this presentation summarize the recommendations of major medical societies and institutions, including the CDC, the FDA, IDSA. And these considerations are more consistent with modifying the standard of care as opposed to developing crisis standards of care. So I think providers that are practicing with the best intent and driven by recommendations from major societies oftentimes have the appropriate legal protection. Crisis standards of care oftentimes require emergency public health orders or executive orders from governors, none of which exist within Region 8 for the blood culture bottle at this bottle shortage at this time. So really, to understand potential legal ramifications, you should talk to your own legal group and your local public health leaders and within your state to understand kind of what those protections are. But again, providers that are doing their best and guided by recommendations from major medical societies, when the standard of care has been modified, have appropriate legal protections in most situations. So that's the end of our presentation. Again, the slides will be available. The document itself is available on our website. And I'm going to stop sharing and turn this back over to our moderator, Dr. Matt Wynia.
Thank you so much. Anuj, I have some questions that we received earlier that I want to get to, but before I do, I just noticed as you were talking that we didn't really say anything in this document about the strategy of asking that blood cultures be approved by the infectious disease team before they get drawn. And I think a lot of places are talking about doing that or are already doing that in some or all circumstances. I guess, do you think of that as sitting somewhere on that conventional contingency crisis spectrum, or is that more is requiring ID approval more of an implementation strategy that you could apply across those different allocation strata?
Yeah, I think it's a great question. So I think it definitely is an implementation strategy. You have to make sure you have the appropriate number of infectious disease specialists to be able to field that number of calls. I think where I've seen it the most is that infectious disease teams create a list of approved indications, and when you want to deviate from that list, then you need expanded approval or a verbal approval from an ID. And part of that is to reduce the number of phone calls, but also to recognize the workflow in the emergency department that, the delay in collecting blood cultures while you're waiting for a phone call back can have real patient harm. So I do think it's an implementation strategy across the board. If there's a list that is data driven and not as restrictive as some of those contingency strategies, then I think it falls on the conventional strategy because it's not going to delay care. It's just guidelines for best practices. When it becomes more restrictive and requires a phone call and there is a potential delay, then that's kind of where you're thinking about falling more on that contingency realm. Because again, I think the classification is entirely based on to what extent is there a potential increase or worsening of patient outcomes.
Yeah. Now, nice segue to where I wanted to go next, which is to Robin. Robin, you work in an emergency department, and I am curious because a lot of blood cultures are drawn in EDs. How significant are the changes that are being made now in EDs experiencing these shortages? Especially, I guess, for anyone who may have logged on who does not work in a hospital experiencing this shortage, for those that are experiencing it, how big a deal is this? Is this a really big issue right now, or is it more like a minor inconvenience or somewhere in between?
Well, I can only speak from my own experience. I mean, I've asked about our own supply, and we seem to be okay right now. Not, and I'm at Intermountain, so that's in Utah and beyond a little bit. However, having brought that up to those that care about that and talking about these guidelines, it's good, I think, in advance to look at them to just know where we're going, because there's certainly things we can do right now to lessen our use of culture bottles. But I think it's a big deal because I don't go a shift without drawing blood cultures. You just don't do that. And so to really look at who should I be doing and who should I not be doing is important. And then there's just these our sepsis bundle. So if patients meet a certain criteria, we automatically in our computer programming it automatically says, well, you're drawing blood cultures for this type of patient. And I've noticed even sometimes just vital signs will be the criteria. So there will be people that have certain vital signs that it'll pop up and say I should be getting blood cultures on those patients that I would never get blood cultures on. So, the doctors don't necessarily order them, but there's this kind of idea that we have to draw blood cultures in a timely manner prior to antibiotics to meet the CMS requirements. So that's a big deal.
Yeah, and what triggered a lot of our early work on this was a webinar over a month ago now, where I believe it was Vanderbilt reported out that they had received something like 10 blood culture bottles the week before. And that's a hospital system with over 1,000 beds. It's an enormous health system. And they were essentially cut off from blood culture bottle supplies. And it made us all that really elevated the heart rate to think, my goodness, could this get to that point where suddenly we have an extreme shortage? It seems like most folks haven't gotten there. And Tim, I wanted to go to you next because we spent a lot of time on really compiling what are arguably in that conventional bucket a whole bunch of really best practices for use of blood cultures at any time, right? So we're not talking about rationing or triage. We're just talking about using resources wisely all the time. And yet a number of hospitals around the country that have implemented these in a more aggressive way because of this blood culture bottle shortage have found that they have reduced their blood culture bottle usage by as much as 30 or 40%. And I guess I wanted to ask you, that suggests these are big changes compared to usual. Best practice is a big change compared to usual practice in a lot of institutions. So what are the barriers that you see in getting folks to adhere to these kinds of best practices? Why weren't we doing these things according to these standards already?
Yeah, that's a great question. I think that is probably why there are estimates that 25% of our healthcare dollars are spent on wasteful tests and practices, and I think blood cultures are probably no different. But I think to answer your question, it's very likely multifactorial. I think some of it is ingrained practices. So things like obtaining blood cultures every time a patient in the hospital has a fever. The knee-jerk reflex fever workup with blood culture, urine culture, or maybe a chest X-ray. So that type of care what we really want is to provide providers to assess the patient and think about, is this really a patient where blood cultures are indicated? Unfortunately, that takes time. So I think that's another part of this. It's easier to just order blood cultures in a patient that has a fever, particularly if you're a cross-covering provider, than it is to dig through the medical record and look to see what's been happening recently with this patient, or go to the bedside and evaluate the patient. So I think time pressure drives overuse of blood cultures. And then I think knowledge gap is part of it as well, or maybe even extrapolation of practices in the incorrect scenarios. So, providers may not know that in the setting of 1 out of 2 positive blood cultures for coag-negative staph, the literature suggests that that's nearly always a contaminant, so more than 90% of the time. Or extrapolating the fact that we do need to document clearance of blood cultures for pathogens like Staph aureus in Canada, and then that's applied to a patient with cellulitis and group A strep bacteremia. So, a well-intentioned extrapolation that is just not really what would be recommended or the standard of care. So I think a lot of reasons, but I think, as you guys have mentioned and alluded to, that this is just a great chance for us to really promote these best practices, and that we do have to talk about resource stewardship in healthcare and really approach it in a number of ways. So education is just one of them. We need to think about, are there ways we can use the electronic health record, clinical decision support, et cetera. So never let a shortage go to waste in terms of promoting best practice and getting guidance out there. So
I'm going to make a t-shirt with that. There's a question that was dropped in the chat here about using pediatric tubes for adults, and is the 3 ml sufficient blood volume for adult testing? I'm not sure who might be best suited to answer that, but maybe Tim, that's to you as well.
Yeah, I'd say that's probably not a strategy that we would recommend. So that would certainly be something that I think would be more in the contingency, probably even more crisis management or strategies, because the yield of blood cultures is really directly proportional to the volume of blood obtained. So obtaining a small amount, 3 cc's or less, will in an adult will definitely reduce sensitivity. So there are data that have come out during this shortage that showed that if you were to obtain 1 adult blood culture compared with 2, the sensitivity of detecting a bacteremia with just using one culture is about 65% to 85% compared with 2 cultures. So we know that even if you just use a single adult culture drawing 10 to 20 cc's, there's a substantial reduction in sensitivity for detecting bacteremia. So I think using the pediatric tubes would, akin to that, be substantially reducing your sensitivity.
And then the other question that's popped up in the chat is around the glass bottles. Are there guidelines for modified validation studies? In other words, will those work on the existing system? And the other one the other piece of that question I'd like folks to reflect on is whether, there's presumably reasons why they switched out from glass bottles. Do they break? Do they pose a threat then to lab workers or to phlebotomists? Why did they move away from glass bottles? And is it an easy thing to just switch back to using glass bottles? Or do the machines need to be recalibrated? That's open to anyone who might know the answer, because
I can answer to parts of that. So yes, to switch to glass bottles, it would be recommended or even required from a lab regulatory standpoint to do a validation of that. So you would have to demonstrate that change in use of this reagent or sort of part of the test is not affecting your test characteristics, that you're still having sufficient sensitivity, specificity. So it would be a change in practice to switch to those bottles. And I think part of the question is, can the validation be modified? I'm not a laboratory director, so I don't know the details of what's required for those validations. But in my understanding is that there is some wiggle room in terms of what's done and what's considered an adequate validation. And so I would expect that there's some flexibility if that needed to be done in this situation.
Does anyone know, was breakage an issue? That, did that contribute, or was that a reason to switch to plastic bottles, or are plastic bottles just cheaper to manufacture?
I think that was part of it, because if you drop those, I have dropped them and they break.
Yeah.
It's a bloodborne pathogen issue now. And so I think that, I'm not sure that it's all of it, but I'm sure it's some of it.
I'll put a link in the chat, but there's PD at Becton Dickinson kind of updated a lot of their guidance just a few days ago. And there's indications about the glass vial situation. It looks like the glass bottle is going to be mostly for the anaerobic cultures, not the aerobic. And they were discontinued in 2022, so some labs may have validations. I don't know how long they last for, so they can refer to like kind of what they did beforehand. So there's a decent amount of this there. From a CLIA perspective, they have the same level of complexity as the plastic bottle. So like I think the handling is not any different. But I'll post this website with a lot of the FAQs that they have there, including the SKU numbers if people are interested in ordering those starting in September.
I guess another question I had, which is kind of a big picture question, but some of the reporting on this has been around the issue, the general issue of shortages and the advice to companies that produce medical devices, goods, et cetera, to monitor the reliability of their suppliers. And presumably, hospitals are getting that same advice, which is to say, monitor the reliability of your suppliers and be ready with a backup. And to have a backup supplier if your sole supplier goes down for some reason. That strikes me as being very difficult to do when you've got a proprietary system like the BD Bactec system, which then isn't compatible with any other blood culture bottles. So, is the advice to hospitals to have a backup system, a whole separate platform? That seems pretty unrealistic. So what are things that hospitals could do or that regions could do, for example, to try and mitigate the threat that comes with having these proprietary systems?
Matt, I think it's a great question. Being a critical care doctor and living through the COVID pandemic, I think about the fact that most hospitals contract with a single manufacturer of ventilators, and you could imagine an issue where that single manufacturer wasn't able to produce the tubing, or there was a recall, as happened with Philips Respironics, and so these ideas of shortages affecting only some hospitals and not others, I think is really not going to go away. And I think it's only through regional coordination and resource sharing that we might be able to. I don't think we're going to necessarily fundamentally change our supply chain. That's going to take a lot more than I think the people on this call are going to discuss. But this idea of like, how can you share resources? Because as we talked about the blood culture situation, we recognize that like there are all these ways that we can transfer patients between hospitals, but transferring a vial of blood actually to a hospital that doesn't receive blood from other hospitals is actually really complicated, and you have to have all these new things set up. And so I think a lot more needs to be put into the idea of regional coordination.
Yeah, Anuj, maybe I'll ask you my other sort of big picture policy question. You alluded during your presentation to the declaration of crisis standards of care during the pandemic. And obviously when there's a formal declaration by the governor, by the public health authorities that we are in a crisis, that sort of authorizes the implementation of the contingency and crisis level strategies, which we recognize sometimes can end up leading to worse patient outcomes, but not as bad as if we ran out entirely, right? So we're trading off potential bad patient outcomes and saying it would be better to conserve this resource by not using it on everyone we normally would, knowing that some of those people might actually be harmed by that, but it allows us to conserve the resource so that we can use it when we really need it, because there will be someone else comes along who really will be harmed if we can't do a blood culture on them because we've run out. That legal protection felt kind of important. And it's obviously not present in this kind of a circumstance. I don't know that it's ever been a declared emergency, with crisis care strategies approved by virtue of, we know this is a response to a very significant shortage. And we've seen quite a few very significant shortages that definitely required people to use strategies for conservation of those resources that may have put some patients at additional risk. Is there anything sort of in between that we should be thinking about on a policy level that would authorize the use of contingency and crisis strategies, short of saying this is a public health emergency and the governor has weighed in? Because that's kind of where we are right now. In order to implement those strategies and have that legal protection, the governor has to sign off on it.
Yeah. I mean, I think to highlight an example of something you're highlighting is the shortage across multiple different chemotherapies, right? Like I think not getting the best chemotherapy clear for a type of cancer clearly has the risk of patient harm. And we know that a lot of hospitals struggled over the last year with different types of chemotherapy access. So I definitely, in the crisis standards of care as a legal entity, lives in the world of politics, unfortunately. There's a lot of barriers to implementation and activation from a political view. There's a lot of resistance to public health orders in general after the pandemic. People have a variety of feelings about those things. And different states, the approach is very different. And so I do think that we need to reconceptualize this idea of strategies. And I think, we were really careful, both in the document and this presentation, to not talk about crisis standards of care, but really talk about the conventional contingency and crisis strategies, and really try and imagine how we can implement those, and really codifying this idea of like a provider doing the best they can with the resources that they have, you know, has a decent amount of legal protection. And even in crisis standards of care with the full declaration, right, you can always be sued for anything. It's just a question of, you know, what are the legal protections that are going to get the suit dismissed or whatever the case is. And I think that, you know, it's, you know, the layman standard is what would a reasonable provider do in the given situation in the absence of a crisis standards of care declaration. And so, you know, I think one of the values of the document we created is that it is a summary of multiple expert groups that really does provide guidance on what a reasonable person would do during these difficult situations. The thing that has never been addressed is that crisis standards of care conceptualizes the shortage or the surge is uniform. And this blood culture situation really highlights a unique situation that you alluded to earlier about, you know, individual manufacturers and hospitals contracting with one manufacturer and not another for different systems. And now a reasonable provider at another hospital that uses the Bioethics system would check blood cultures potentially, but not in a bacteria. Like, so it's created this new quagmire that I think really is going to require some rethinking about how we address shortages across regions, across cities, and across the country.
Thank you. You know, Tim just said he's got a practical tip to pass along, which makes me think, why don't we end with that? We've got just a couple minutes left. And I'll go to Tim first, and then Robin, and then Anuj for any final comments.
Yeah, thanks, Matt. I just wanted to share a thought on this practice of drawing and holding blood cultures in the emergency department on the first stick. Anuj discussed that about how that can lead to waste. If you're like us, when you're tracking your blood culture utilization, we looked at blood cultures that are performed on a weekly basis as our metric of tracking use. If you do that, you will not identify all of the blood cultures that are drawn and held and then thrown in the trash due to the draw and hold practice. So those won't be reflected in your utilization rate. So it's very important to, when you're tracking blood cultures, to really assess if this practice is going on in your institution. What we found is that we have phlebotomy that draws almost all of our blood cultures, so we don't think that that's a common practice in our emergency department. But if it is a common practice in your emergency department, it may substantially be affecting your blood culture bottle utilization rate, but not show up in blood culture performed metrics. So I just wanted to share that because we hadn't really thought of that potential problem until we sort of got a little bit further along in this.
Thank you. That is a very practical tip. Robin, do you have any final concluding thoughts or suggestions for the audience?
No, I don't, not really. My thought has been that this has already changed my practice. So I really like the idea, and I think it was mentioned before that this may lead to best practices of how we should be drawing blood cultures anyway. So for me, it's like I stop, pause, have a conversation with the doctor. I don't hold bottles like I have before, because why, again, why not get the blood that I need to while I'm poking the patient? So it's already changed my practice, even though, we're not necessarily in a contingency or crisis mode. So I appreciate it for that.
Excellent. And Anuj, you get the last word.
One, thank you to the panelists and everybody that contributed to the document. That's, I think, the first and most important thing. And then also to the MPRDHRS staff that helped set this up, Katie and Jericho, and a lot of other folks, Steve, who like really helped us get this going. The last thing I would say, I think, is that this shortage will end. I think we got an updated sense of that. It's going to, the supply is going to improve it sometime in September, although it might not be the most common supply that we're used to with plastic bottles. But I think what we've highlighted here is that this type of shortage is a vulnerability in our health system. And it is an intersection of like how hospitals approach things with public health. This isn't necessarily like a, a true public health disaster, but in some hospitals that have implemented very restrictive practices, it has a lot of patient outcomes. So I think it really pushes us to think of how hospitals, despite the fact that they all have different profit motivations and compete for patients and things like that, about how hospitals can work together for better resource sharing. And my hope would be that, we learn from this when it hasn't been as severe as I think some of us thought it might be, although, for some places it's getting worse. And how do we take and learn from this and apply it to future problems that might arise in the supply chain? And I think that's lessons learned is going to be a really important thing that every hospital has to reflect on as the shortage resolves itself.
Well, thank you all very much. And thanks to everyone who joined us today, and look forward to the feedback. Please do fill out the feedback form. It's just, I think, 3 questions. It'll be really fast. Take care, everyone.